In these stations, you can find the file, big file like this, usually is about 20 pages. Have the history of the patient, have the detail, have everything related to the patient, and you need to go through all this. Okay. The writing of the file is usually what we call it a script. What's called it is way of writing look like handwriting. So sometimes if we don't use for this handwriting, it's become difficult to you. Okay. You have all the investigation of the patient, picture of X-ray can be separate, so you can find anything. Okay. So I start one by one. So just anyone need to start to see this scenario. They can start. I can follow up with him, or we can read it together. Up to you. Anyone need to see this scenario? It is common scenario, by the way. Okay. Any volunteer?
ماشي أنا هجرب حظي.
All right. Okay, Dr. Muhammad. Okay. So you can see this scenario. Usually you have a paper. You can write some notes. After that, you go to the station, the second station. The second station is you call the examiner by phone also. So you can call by phone. Okay. So Dr. Osama, we leave you to the second session because someone is ready. You need to say something, Dr. Osama, or okay. So we can start now. So Dr. Muhammad, you see the screen.
No, the
After
screen is not shared yet.
not shared yet. Okay. Okay. All right. After you finish the page, just tell me I go to the second page.
تمام. Before the consultant in charge was to know about the case done by Mr. Klaus, 75-year-old lady with a background of CVD, mind liver failure, underwent mastectomy, axillary clearance for breast cancer 2 days ago. Harrison constated fearful anxiety, discomfort with shortness of breath. Blood came out from the suction drain. The patient is due to go home tomorrow, but due to this complication, she will postpone. Her daughter wants to take her home in her home, which is 60 miles ago from the hospital. She was persuaded that her mother would be best with her. You have spent the last 20 minutes trying unsuccessfully to explain to her daughter that discharge today is not for the patient's best interest, especially since her home is away from the hospital. The daughter is very determined and wants to have her way. She is a school teacher out of the home in the morning, and her husband works also. She has 2 teenage daughters in secondary school. Patient history, Mr. هو الخط ده بس مش واضح شوية.
ما هو this is the way of writing you can see in exam because this is the handwriting because it is the real patient file. So
تمام.
usually it is handwriting. This is type is used in the word mimics the handwriting.
Okay.
I can read it to you. It is Miss Anne Mary, 75 years old, woman with a background of chronic obstructive airway disease with mild left ventricular failure, suffer from lump in upper outer quadrant of her left breast, firm consistency, 4/3, attached to the skin, no bodorange, no tethering, no buckering, mammogram, macrocalcification and irregular mass, 5-needle aspirated cytology, C5 mean malignant cell, CT, thorax, abdomen, and pelvis are normal. Bone scan is normal. Operative detail, the surgeon is Mr. Browns, and the anesthesia is Rupin, and procedure is left mastectomy axillary clearance for breast cancer. 2 suction drain was inserted, 1 in axilla and second in the breastbed. Post-operative follow-up, first day, normal, vital sign, no pain. Second day, the patient developed axillary discomfort with shortening of breath and 500 cc of blood come out from suction drain in the axilla. A blood sample is taken for hemoglobin and follow-up planned for exploration of axilla and secure bleeding. Full blood count 2 days post-operative. It is hemoglobin is 9. This is the vital of the patient. You can take notes if you found something abnormal.
تمام.
Not necessary to be abnormal, maybe okay. Apart from the hemoglobin is low. After that, you can see the arterial blood gases. You can take a notes about it also.
Okay. Yeah. Page normal.
Okay. After that, we have chest X-ray. You can see the left breast is removed and is look like normal. Okay. So after
تمام.
that, after you read all this, you go to the second room. In the second room, you can find the telephone. And first thing you will do it is just call and give him your telephone. What is your number? So you tell him,
Okay.
I am number, for example, 6120, whatever your number, because the examiner, you don't see the examiner even like now. You see me in the screen, but in the exam, you don't see the examiner at all. Okay?
تمام.
And
Okay.
it is important if you need the notes. This is the what you call him is not the surgeon who makes the surgery. It is the doctor in call. So if he asks you
Okay.
why you call me, because you are the charge in the call. This is station is coming the last exam, and still some students have misunderstanding. So you can start. I just share for your friend, but you can start to speak to me. Okay.
Okay.
All right.
Okay. Hello, my candidate number is 33.
Okay.
I'm the SHO working for Mr. Prowse in hospital. I'm calling to
Yes.
call. I'm calling for the on-call consultant. Can you please confirm me? I'm calling to.
Okay, I am Mr. Wolfson. Usually, the name of consultant is written in the paper. Usually, in the second room, you have the copy of all paper. If you miss any name, you can check the names. All right. So I
Okay.
am Mr. Wolfson. Okay. All
Okay,
right.
Mr. Professor. I'm speaking to you to be given an advice around a patient in the postoperative day two, after mastectomy and axillary clearance. She had one of her drains with 500 cc of blood.
Okay. Okay. So why you call me?
Because you are the consultant on call.
Yes. Okay.
Uh,
But what is the problem you have to call me?
um, Mr. يعني أقول
Why you call me? What is the problem?
the problem is my patient drain is draining blood, and she wants to leave hospital against medical advice.
Okay, so now you call me or you call the consultant because the patient need to discharge against medical advice. Because the problem happened in the last exam just a few days ago is that many of the student mentions that about the case and about the bleeding. Actually, it is not a problem. The problem is this patient need to discharge against medical advice or her daughter need to discharge her. So the
Okay.
examiner usually ask you, is this patient have the capacity to make his own decision, or
Yeah.
she is not alert for that?
Yes, I think my patient have the capacity to make her own decision.
Okay, so if the patient has the capacity to make their own decision, so in this situation, whatever her daughter say, we don't care by her daughter because the patient is adult, is alert, is conscious. So they usually we depend on the patient. Right. After that, the examiner asks you some question related to medicine. So you mentioned this patient have a swelling in axilla. What is this swelling called? What is this?
I think it may be hematoma or seroma.
I don't think it is hematoma or seroma. Okay, so what you did for this as a management for this hematoma or seroma?
Uh, I inserted a drain.
You know, the drain is already inserted at time of operation. You see the patient post-operative. So what you did, you take a blood sample looking for hemoglobin. If the hemoglobin is less than 8, I give here blood. Okay,
Okay.
and I prepare here tomorrow, for example, to have a drainage of that evacuation of hematoma and secure the bleeding point. Okay,
Okay.
so the already is the trade is present. Okay, so what you expected the cause of this bleeding? What this
Uh,
bleeding come from?
I think it may be due to a direct injury to a vessel in the operation or slipped clips or stitches,
Okay,
or
so
because
usually it is due to slip lecture or secondary hemorrhage. Okay. All right. And of course, we mentioned in the script or the patient file that hemoglobin is 8 or below 8. So you give her blood, is already you're giving her blood. Okay. You mentioned this patient have shorting of breath. So what you did for this shorting of breath? Or what you expected to do for this shorting of breath?
uh, I'm going to put my patient on oxygen
Okay.
supply and search for the cause. Uh,
So how to know the cause?
she,
You give
she
her
has a past
oxygen.
history. She has a
Yes,
past
but
history of
what you will
COPD.
do for her to know the cause now?
I'm going to take bloods and arterial blood gases and make a chest X-ray.
Okay, so arterial blood gases, yes, chest X-ray, yes, and after that
Uh,
or better, what you need to do?
I can do a CT of the chest or an
No,
ECG.
no, relax, doctor. It is better to consult the chest physician. So what you
Uh,
will do, I will did chest X-ray. I will ask for arterial blood gases. I examine the patient, but of course I take the help of chest physician or any medical doctor or doctor in internal medicine. Okay,
okay.
is this patient can be pulmonary embolism?
Yes, it can be
This is patient how many days post-operative? Which how many days written in the script?
two.
2 days. It's a two. Okay. Is after 2 days of surgery in this patient can have pulmonary embolism or difficult?
It's difficult, but this patient have malignant tumor, so it might be bedridden from before the operation.
No, no, not necessary. But usually pulmonary embolism is occur after 10 days. In some
Okay.
cases, pulmonary embolism can occur early. Like what? In which
Uh,
cases pulmonary embolism can occur third day, fourth day, not 10 days.
for long bone operations,
Long what?
long bone operation.
Usually it's a fracture bone or femur or bone operation or liposuction, or if the patient already bedridden before the operation for long time. So can be the
Okay.
cause. Okay. So what usually the pulmonary embolism presented by?
The pulmonary embolism presented by tachycardia, dyspnea,
Okay.
and hypotension.
Okay. And of course, low oxygen saturation.
No
How to
oxygen
diagnose or confirm diagnosis?
by CT angiogram.
CT angio for the lung. Okay. All right. So now you can see in this script, so you tell the consultant first why you call him. After that, he asks you some question, medical question. After at the end, it is important to summarize and also he tell you, so what is now, what shall you do now? You mentioned that you stay about 20 minutes to speak to her and she have no response. What you will do?
I'll inform the patient and his daughter specifically about the complication that might happen to her after her discharge against our medical advice.
Okay.
Uh, I'll give them a legal document stating that she wants to be
So who will
discharged.
sign this document, the patient or her daughter?
The patient.
The patient. So the patient will sign the consent. Okay,
Yes,
good.
before the patient
All
is
right.
capable.
So this patient will go to about 60 mile. About 60 mile is about 100 kilo away from the hospital. So any advice to give here about apart from that? What have if the patient have complication or become worse? So what is your advice to her?
I'll advise her to go to the nearby hospital or come to the hospital and asking
No, to
the.
come to your hospital is so far. 100 kilo is so far. The patient will die in the
Okay,
way.
okay,
So
to immediately the nearby
how the
hospital.
patient knows the nearby hospital?
Uh, I don't know.
So I think it's better to tell the patient the name of the nearby medical center or hospital and the telephone contact number for this place. Okay.
Okay,
Can you summarize at the end? How to summarize? Just tell me how to summarize at the end.
okay. Mrs. Anne is in the postoperative day 2 after mastectomy with axillary clearance. She has now axillary swelling with 500 cc in the drain. Our main problem that her daughter wants to take her discharging out from hospital against its medical
Medical
condition,
advice. Yes.
against medical advice. And I have spent at last 20 minutes to consume to pursue her daughter that discharging will not be able and is not in the. But now I'm going to talk with the no matter the daughter. If,
Discharge against the medical advice. Okay.
okay,
All right. So you tell her she will sign the consent, and after that you tell her the place
a
or the
warning sign.
contact number of near center or medical center, so she can call the ambulance and can come to them. Okay.
Okay.
So as you see, this is easy station, but still some student they have two problems. The first problem, what is the aim? You call the consultant is not to describe the case because apart from it is not his case, this is hematoma is not urgent, but it's the urgent situation is the patient insisted to discharge against the medical advice, so you call him for that. Okay, after that, when you summarize at the end, of course, no need to describe the condition from start to tell this patient have a lump and she take fine needle and have mammogram because this is if not important to him. The important is what is we make this decision for. Okay, so it is clear. Anyone need to ask anything? This is a station is very, very, very common. Uh, come many times. So anyone need to tell something or need to ask anything about this condition? Okay, Dr. Osama, you need to ask anything or you need to take the second case.
No, okay, everything is okay, doctor. I
All
think.
right, okay. I think the second case is the case come to you to exam. In the exam, you have what is called dissecting aortic aneurysm or hemothorax.
Descending aortic aneurysm.
Okay, we still make it hemothorax in our version. I think I remove change it a little bit. You need to take it, or we can ask anyone else.
Okay, I can take it.
Okay, so again, this is the second common question, and of course, for the student who is the first time to enter the exam, usually the scenario each time have little change. This is scenario, as you see, you can, I share the screen or you don't see it. I think I share the screen now. Okay, so Dr. Osama, you can see the screen now. You call the cardiothoracic consultant to refer polytraumatized patient to his unit. 35 years old man with RTA, road traffic accident, blood pressure 100 over 80, glaucoma scale 14 over 50, with the left hemothorax and fractured left femur. The same scenario can found widening mediastinum, so the same condition. You put a chest tube, they drain 200 fresh blood at the time of insertion, followed by 200 second hour, and the same after third hour. You are Dr. Richard, so the candidate, his name is Richard. If you forget the name, just tell your real name. working in emergency department. You will speak to Mr. Wolfson, the cardiothoracic consultant in charge today about polytraumatized patient. Refer to him to his unit. And again, you need to use for this way of writing, because this is the handwriting. It is in the word, it's called the script brush. So it's Mr. Man. Mr. Man Worker is the name of patient, 35 years old, motorcycle, came to ED, emergency department by ambulance after accident 3 hours ago. On the examination, Glasgow scale 14/50, swelling left side, airway is patent, and the patient can speak with us. Breathing is normal. It is important to know we ask you about these details so you can have the answer from the script. No tracheal deviation, normal percussion and auscultation, chest X-ray referred left-sided hemothorax, insertion of chest tube, drain 200s and 200s and 200. We send the blood sample for group and safe. We send the sample for full blood count, blood sugar, and arterial blood gases. Hemoglobin was 7, and we give the patient 1 unit of blood, because means that the hemoglobin is low. X-ray for left femur show fracture shaft femur. Informed the orthopedic team, and they put the patient on Thomas splint. Abdomen is normal, confirmed by fast scan. And that's it. Okay.
Mm-hmm.
All right. So you can start now, Dr. Osama.
Yeah.
If
Hello.
you need to make it widening mediastinum, we can make it widening mediastinum, no problem. Make it widening
Okay.
mediastinum just to be used.
Okay.
Okay. You
Okay.
can start.
Hello. My name Dr.
Hello.
Osama. I'm a CHO doctor. Please, can I
Yes.
check to confirm to call to the doctor thoracic surgery
Yes,
about
I'm
the patient?
Mr. Wilson. I'm the cardiothoracic surgeon in call today.
Okay. How are you, doctor? Doctor, please,
Okay.
I need to refer the patient for you. Patient polytraumatized patient.
Okay.
The name of the patient, Mr. Man, as the patient is polytraumatized and have a patient with income Glasgow coma 13/15. Patient have chest trauma, and the patient income is the airway is patent and the
Okay, so
breathing.
you make it widening mediastinum. The airway is patent. Okay, go on. Yes.
Yeah, the airway is patent of the patient, and the patient when you check to the patient have blood pressure, uh, I think 100/80, and the patient when do the chest X-ray show the patient have a left side pneumothorax and have a widening of the mediastinum,
Okay.
and the
So
patient
why
have.
you call me Dr. Osama? Why you call me? You make
Yes, doctor.
everything. You say the airway is okay, patient is okay. You give him blood. Everything is okay. So why you call me?
Yes, doctor, I'm call you because the patient have a widening of the mediastinum and the patient need thoracic surgery. Maybe have patient have a large vessel injury. That's
Okay.
what.
So you mean that this patient you sent it? So shall I go to the hospital now or can wait till tomorrow?
No, it's the urgent case. I need to prepare the patient and send you to today because it's the urgent case.
Okay. All right. So you call my hospital just to prepare the theater and all this or not?
Uh, Actually, I'm not called to the theater. No.
Okay. So after you finish calling me, I think it's better also to call the theater and the anesthesia. Just I need to ask you some question.
Yeah.
Okay. So all right. Is this patient, oh, apart from this, how to confirm what you did for this patient as regard the trauma? You mentioned airway and others. So can you check with me everything about that?
Yes, the patient is the airway. When talk to the patient is the airway patent and the
Okay,
trachea
so
is.
airway is patent because you took the patient, he can speak. Okay, what about breathing?
Yes, the breathing is the patient can take the breath
It's
and
normal.
centralize.
You mean normal?
Yes, and centralize
Yes, can be
trachea.
tension pneumothorax.
No,
This is
because
tension. Why?
because this trachea centralize it, and the patient know any sign of the tension pneumothorax.
Like what?
like hypoxia, dilated vein, and displacement of the heartbeat, and low of the saturation, and a severe chest pain.
No, we speak about tension pneumothorax. So no tracheal shift, no
Yeah,
hyperresident, normal
and no
airway.
hypotension. Yes,
Okay, hypotension can occur in all conditions, but more specific for tension pneumothorax is no tracheal shift, normal percussion, and
yeah,
auscultation. So
yeah.
A, B, what is after that? What is you didn't see?
See, it is the circulation is inserted too large cannula to the patient, and the check to the blood pressure 100 over 80, and the patient take blood investigation show the hemoglobin it's 9, it's 7.
Okay, so give him blood because the hemoglobin is below
Yes,
than 8.
yes, and
Oh,
given the blood 1 unit of the blood, we started to give it.
all right, okay. So what about the lower limb? What you say, you
Yes,
mentioned he have a fractured femur, left side. So what happened to the lower limb?
yes, the lower limb patient has a fracture of shown when comes a swelling of the left side of the femur, and the orthopedic consult called orthopedic, and he is done Thomas splint to the
So why he
patient.
did Thomas splint, not did fixation and the plate and the screw, for example?
Uh, because now is an emergency case is the more priority to the chest because injury to the large vessel, and maybe after the finish to the stabilize the patient and maybe need transfer to the thoracic surgery. After that we need the orthopedic maybe need to do
All right, so
fixation.
just put a Thomas splint as a first aid. So
Yeah.
what is the important you check for from surgical point of view to check in this leg?
Yes, the surgical point I need to the check to the pulse of the patient and show
Which
to the
pulse?
capillary show to the dorsalis beats and
You mean
anterotibial
distal pulse?
yeah, yeah,
So
and
you
capillary
already
field.
checked the distal pulse is okay.
I'm sorry, I'm not to check to the chest. I don't know to check to the pulse at this time. I will check after
No.
calling.
It is written in notes. You check the pulse, by the way. I think in the other notes they write they
Uh-huh.
consult the orthopedic and the distal pulsation is correct, and they
Okay.
check by Doppler. What about
Yeah.
the abdomen?
Yes, the abdomen patient when you do a fast scan show to the
What is
patient
fast
have
scan mean?
focal associate focal
Focal assessment sonography
at
for trauma.
trauma.
Okay. All
Yeah,
right.
yes, and the patient has
All right.
some free small free fluid. Mhm.
Or no free fluid, nothing. So, okay, well done, Dr. Osama. But if you see again, I just share with you the scenario. Of course, usually in exam is a big paper or long paper, so you can find everything I ask you is written here. For example, I ask you about airway is patent, and you see the screen.
Yeah,
Yes, the
airway
airway
is
is patent
patent.
and the
Yes.
patient can speak with us. So everything is written. Breathing is normal, no tracheal deviation, normal percussion and auscultation. And of course, they speak about chest X-ray, whatever. He take a blood and they give a blood. Uh, I think I added in other versions that we inform the orthopedic hepatomas abdomen done by fast scan. No, maybe I added in other, so I added also. Okay, so can you summarize?
Yes, doctor. I have a come today. Our patient arterial traffic accident. Patient class glaucoma is 13 over 15, and patient when he is come do the some investigation. Patient has blood pressure 100 over 90, and patient do blood investigation have 7, and patient received 1 unit of the blood. And when do chest X-ray have pneumothorax and widening of the mediastinum, and have the fracture of the femur. Now and we do fast scan is the free of the patient. The and we need to transfer patient for you
Okay, so need to transfers and you call
do
the
if you
others
need.
and all this. Okay, all right.
طبعا دكتور في اسئله
Oh,
ثانيه كانت انضافت هي في
all
الستيشن
right,
دي.
I come to you. Okay, like what?
الاسئله اللي انضافت كانت what's the type of the management for this patient, what's the name of the operation, like
You mean thoracotomy?
TVR, transvascular aortic repair.
No. We don't ask more detail, but
And maybe
simply
open heart.
you can tell I just put a stent. Nowadays, by stenting even in the aortic aneurysm or impending rupture, you can just put a stent. So just take it easier. Okay. What else you need to ask about?
And ask me type of the transfer to the patient.
Okay. So what is the type of transfer to the patient, by the way?
Yes, informed I need to transfer to the patient. I with ambulance of the blue light ambulance with the ICU with full resuscitation equipment like
Uh,
DC shock and mechanical ventilator.
Okay, usually it isn't all, but it is better to transfer with the doctor. So just tell him with the doctor. Of course, all the ambulance all over the world have oxygen, have intravenous fluid. Of course, in some centers they must have DC shock, but it is important just to mention that
Yes, because
it
the
is
doctor he
rapid
asked me.
transfers and with the doctor. And before that, I contact the hospital just to be the theater is ready and anesthesia is ready. So when you reach the hospital, everything is ready in your theater. This is because the other hospital, if the same hospital, you call the people in the same hospital. Okay.
Yes,
All
and
right.
doctor please ask me. The examiner asked me, "What's the equipment you just need to the ambulance?" I inform CPR equipment and mechanical ventilation and and I need transfer with the patient is the blood and I need yes
You need what?
uh, I need to the transfer the company with the patient
Yes,
a
of
mechanical
course. This is
ventilator.
patient is transferred with the doctor, can be from emergency department or from anesthesia because this patient can be collapsed at any time. Okay, this
Yes,
is
because
again is very common. And again, Dr. Osama did it well because you need to tell him from the start, I need for urgent thoracotomy because thoracotomy have many indications. First indication, if the insert chest tube and 1 liter and a half is coming by after insertion, or you insert chest tube and have 200, 200, 200, or if the patient have widening mediastinum aware in the X-ray. So in this scenario, we have two versions. One is the hemothorax, second is widening mediastinum aware in X-ray. Both are urgent, both need thoracotomy or intervention and transfer to cardiothoracic center. Okay. Anyone have any query, any question? I think I hope that all some in June, some in April nearby exam, so will be easy inshallah.
ان شاء الله ان
Uh,
شاء الله تكتب من
oh,
هالقصه قصه
inshallah,
الامتحان
don't
هاي.
worry. Don't worry. Okay. I think the second is the patient with hemicolectomy. Patient uh, all as a patient is Oliguria. Okay. The second scenario, which is common, is a patient have after operation and have Oliguria. All right. Anyone volunteer?
Can I take it if no
Yeah,
anyone?
doctor.
Okay, Dr.
No,
Hamza. Okay. Can? All right. So, okay. So I just share the screen and again, I can read it maybe easy. So this is, you are Dr. Richard, SHO for Mr. Wolfson. You will call Mr. Browse, consultant in charge today to tell him about a case that is not under his supervision. Mr. John Carter, this is the name of patient, 65 years old, patient in the HDU high dependency unit. The high dependency unit nurse call you as the patient is olguric after right hemicolectomy. Mr. John Carter, 65 years old, had unexplained anemia, iron deficiency anemia, loss of weight 5 kilo in the last month, no alter bowel habit, no bleeding per rectum, and no tenesmus or fecal incontinence. Abdominal ultrasound is normal. Colonoscope show mass in ascending colon. Biopsy is adenocarcinoma. Tumor marker CAA is high. CT, thorax, abdomen, and pelvis are normal. Operative detail, the surgeon is Mr. Browis and anesthesia is Ruben, and the procedure is right hemicolectomy, no colostomy or ileostomy. Have bleeding during surgery and take 2 units of blood and 1,100 ml of normal saline. Hemoglobin was 12, dropped to be 10 during surgery. Tube drain is inserted in the right paracolic gutter. Post-operative follow-up, blood pressure 100/80, pulse 120, temperature 37. The abdomen is lax, no blood from the drain. Full blood count post-operative hemoglobin is 11, hemoglobin is 9, low. And this is the liver function test with normal. Renal profile urea is high, and arterial blood gas is okay. And I think we have this is a patient medication. The patient takes gentamicin, and the fluid chart is the patient take 1,100 ml of saline, and urine output is just 440 or 40. Chest X-ray is okay. All right, so this is what you show in the file, usually big file, and have everything related to the patient. Anything you need to stop on it to see it again?
Okay, no.
Okay, so you can start. I just share the result with the student. Okay, go on.
Okay, hello. I am Dr. Richard, working for Mr. Mann. Can I check that I am calling to the on-call consultant, Mr. Browse?
Yes, I am Mr. Brown, the surgical consultant in charge today.
Okay, Mr. Browse, I have a case of Mr. John, 65 years old, who presents now with Oliguria post-operative right hemicolectomy. So, can you accept my referral?
Oh, all right. You don't refer. You just call me to ask my advice. Okay. So you mentioned this patient is oliguric. So what you mean by oliguria?
I mean, the patient, the urine output is 4 after.
No, what is definition of oliguria? Oliguria is urine output less than 500 ml per day. Okay.
Okay.
What is normal urine output?
Normal urine output half up to 1 milliliter per kg per hour.
Per hour. Okay. All right. So what is the cause of oliguria in general? In surgical
Oliguria
patient.
may
In
be
general, in surgical patient.
okay, may be related to pre-renal causes.
So you have pre-renal, renal, post-renal. So we can start by pre-renal like what?
Pre-renal vascular injury.
No, pre-renal can be due to dehydration or vomiting. Okay. All right. I just come to this question again. This can be post-renal. How to know that it is not post-renal cause?
After I insert the urinary catheter to the patient and check the
No, the
urinary
patient
catheter,
is already have urinary catheter, so you need to
which is
of course
not blocked.
you need to check it's not blocked, so it is post-renal cause. Okay. All right. So what is about renal cause? What is
Sorry,
the renal cause of oliguria?
renal causes related to vascular injury or tubular injury in the glomeruli.
No, can be more specific and an easy way. I just show you the script again. If you remember the script, I share with you again the script, not the presentation. We
Okay.
put to you, we put you this. What is this? Medication, like medical
Gentamicin.
chart. Okay, so why you put it? Of course, I just tried to write gentamicin, but it's usually have a lot of medication. So one
Okay.
of what is the cause of renal cause can be nephrogenic drug or nephrotoxic drug like
Nephrotoxic.
gentamicin, amikane, or some steroids or non-steroid anti-inflammatory. So it is important
Okay.
everything in the patient file have a significant. Okay, so you mentioned can be post-renal, so can be obstructed catheter, and you try to sort that. Can be renal cause, so we check the medical medication given to the patient, and this medication can give an idea if this nephrotoxic drugs or something like that. Okay, so back again to pre-renal cause. So what is pre-renal cause?
Pre-renal cause like dehydrations, and also the patient has 1,100 milliliter of saline, which indicate may be related to dehydrations.
So you mean that it is not enough. So what is supposed to give the patient? How much you give the patient?
I will start by give the patient 1 up to 1.5 liter of saline
No,
uh,
per day, how many liter you need to give to the patient? At
per
least
day.
per day.
Um, I think one. I think 1,500 milliliter up to 2,000 milliliter
No,
saline.
usually in adult in surgery we give 2 to 3 liter, usually 3 liter, not
3 liters.
1.5, 3 liter. This
Okay.
patient is dehydrated, he don't take enough fluid. Okay.
Okay.
All right. So after that, we mentioned that can be renal, pre-renal, post-renal. Of course, I will ask you about vital signs. Vital sign, you have it already. What about the
Okay.
abdomen? Is any problem in the
Uh,
abdomen?
no, regarding to my examination, the abdomen is lax. And also, no plugs in the drain.
Okay. So of course, if the patient have a drain, it means that no collection inside the abdomen or no internal hemorrhage in most of the cases. So why this patient have colostomy or ileostomy or not?
Uh, Colostomy?
This
I don't
patient
know.
have ileostomy or colostomy or not? I bring it back again. I bring the script to you again. Okay.
Okay.
Of course, again, in the exam, you have the same file inside the same row. So you can find two files, one in the preparation and one. You can see the script now. Okay.
Okay.
So they write the procedure, they write the operation, the name of surgeon, all this. So right hemicolectomy, no colostomy or ileostomy is written here. Okay.
Okay.
So why no colostomy or ileostomy?
Mm, I don't know. دكتور رحيم
يمكن الشبكة فصلت عند الدكتور.
تقريبا.
I think something in the connection, but it's okay. All right. So, doctor, you hear me now?
Okay. Okay.
Okay. So, why we don't have ileostomy or colostomy in right hemicolectomy? We need it or not need it?
I think not needed.
Why not? Yes, but why?
The patient is not deteriorated. We
No, 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 no,
we do
doctor. Are you working surgery or you are away from surgery?
away.
Are you in surgical practice? Okay, so usually left hemicolectomy, you must have colostomy or ileostomy. Right hemicolectomy, no colostomy, no ileostomy, because the right side, the fluid, it is a fluid, so no need for colostomy or ileostomy. Colostomy or ileostomy done in the left side only, not in the right
Okay.
side. The right side, you just remove the right colon, you make anastomosis between the terminal ileum and transverse colon. All right. So
Okay.
this is a lot. Again, everything is written in the script, by the way. Of course, laboratory investigation done, you know it.
Yeah.
If you check the operative notes, if you check the operative note, what you note in the operative notes? This
The
patient,
hemoglobin dropped from 20 to 10, and also the patient take
take a blood.
the
So it means that he gave him a blood. Okay.
two
You think
units.
this patient in bleeding now?
Yes, maybe
No, 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 no,
related to
doctor,
dropping of
relax, relax. It's not in bleeding. Why it is not in bleeding?
the abdomen is lax until now, but the hemoglobin showing
Okay.
dropping.
No, the hemoglobin is dropping because the patient have bleeding during operation. So this is patient have no bleeding now because the abdomen is lax. We have a drain and the blood pressure is not decreasing. Okay.
Okay.
So what is your cause of Oliguria now? What is your opinion?
I think maybe related to dehydrations.
Dehydration. Okay, so
1000
due to
and one.
hydration, because the patient don't take enough fluid. So if this
Yes.
patient not improved, what else we can do to know is this hypovolemic, hypervolemic, all this? What shall we do? This patient
Um,
in HDU, so what can we do to him to know what is the cause of this drop of the blood pressure or oliguria or whatever?
After I
Okay.
check,
All right. So you know what is the fluid channel test? You know about this or not?
yes, I
Okay,
start.
what is this?
I start first by giving the patient 20 20, 50 up to 500 milliliter of normal saline. And if the patient showing no response, I will repeat this until
Okay,
four
you see
times.
the screen, doctor. You see the screen.
Okay.
You see it.
Yes.
What's the meaning of this curve? You need to draw this curve in exam. So you give a fluid, and the CVP become high, high, high. So it is hypervolemic, or high and the drop again, normal volemic, or drop more, it is hypovolemic. Okay, so this is the
Okay.
CVP, and this is the fluid challenge test. Okay.
Okay.
All right, so it is important to remember fluid channel test is asked more frequent in exam. All right, so
Okay.
at the end, anything you need to tell me?
I would like to summarize what we are going through. Mr. John is oliguric postoperative right hemicolectomy with no colostomy or ileostomy. Also, the cause may be related to dehydration as the patient
Maybe or
not
related to
related to
related
dehydration.
to hydration.
Also, the patient take the drugs which may be nephrotoxic, gentamicin.
So you stop this drug.
Yes,
You will stop it. Okay.
yes.
All right, what else?
And also, I insert urinary catheter which is not plugged. So I will start fluid resuscitation for the patient, give more saline, more fluids as the patient receive until now 1,100 milliliter
Okay.
only.
All right. Okay, thank you. So our aim from this station, in the patient file, you have many charts. You have operative chart, you have fluid chart. Some country called it in input and output or IO chart. You have operative detail, you have medication. So it is important in this situation you look into all. For example, suppose Dr. Hamza again, suppose this patient have hysterectomy and have no urine. What you expected?
Has sorry,
Hysterectomy, female patient have hysterectomy and oliguria after hysterectomy. What it could be?
I think maybe related to ureteric injury.
Yes, usually is ureteric injury or ureteric ligation or block or something. So that it's very common. And in some country, for the beginner for hysterectomy, they put ureteric catheter, metallic catheter in the ureter just to avoid injury of the ureter. So it's very important. Okay. So the aim of this station, you look into operative detail. Maybe hysterectomy and the patient injured, the surgeon injured the ureter. Or maybe the patient have bleeding and become hypotensive and they need blood or need more fluid. Second, you're looking for the medication chart, looking for any drug can be nephrotoxic like aminoglycoside or gentamicin. Looking for the input and the output, maybe the patient don't take enough fluid. So the aim of this station in big file of the patient, you need to looking for all. Of course, but I don't make it here. You need to also to looking for electrolyte like potassium. If you see urea is little high, but just to know if no any renal impairment. So it is very, very, very important to notice that. Okay. Any question about this, by the way? Dr. Hamza, you entered the exam when?
June.
June. Okay, so you still have a time. All right. Okay, so it is important to see. By the way, you can find my record and others. Okay, who is the fourth? Is anyone more? Anyone?
عفوا دكتور انا عندي
Yes.
شوية أسئلة بس.
All اسأل يا دكتور أسامة.
هو في الامتحان دي السيناريو فالاكزامينر ask about is the patient could be the patient is the septic or the patient anastomosis leakage فانا قلت له لا فقال
هو
لي
بص
how
حكايه
you know is not
الانستوماتيك ليكج دي عشان برضو هي يعني is coming the exam this yesterday. Anastomotic leak to occur is occur after how many days?
about 4 to 5 days.
5 days. So anastomotic leak to occur need 5 days. And if the patient have a drain and the anastomosis happened, usually the intestinal content come from the drain. So it is
Yes, that's
anastomotic leak or not, it is easy to be judged by the day and by the drain.
because
Okay.
and yes and ask me about قال لي فقال لي انت قلت لي is not anastomosis leakage قال لي في some investigation you don't mention me how to know is the patient infection or no فانا فضلت اقلب في الورق فحط السي ار بي in the last of the
لا
paper
لا لا
فقلت
مش
له
السي ار بي. بص يا دكتور اسامه،
and the
هو
fever
احنا دلوقتي maybe some of the students know that what is recently the indicator of severity of sepsis. Recently, last 2 years, they found that what is the indicator of sepsis. In our time, it is leukocytosis and other. In my father time, it is CBR and the ECR, erythrocyte sedimentation rate. But what is in your day?
clinically I think
Lactate. واحد أو محمد علي say lactate. So serum lactate is the main indicator. So
more than
nowadays, في كل in each scenario, in all scenarios, we put serum lactate. If the serum lactate is within normal, so it is not severe sepsis. Can be infection, but not severe sepsis. So nowadays, serum lactate is one of the indicators. He need to ask you about this. But CBR and erythrocyte sedimentation rate or C-reactive protein can be high in any infection. But also, if we have an anastomotic leak, but we don't depend on it, we don't wait till this to happen. Okay, the next scenario is very common also about the, I think, bile leakage after laparoscopic cholecystectomy. Anyone need to take it? Anyone? Dr. Mustafa Shami, you is anyone entered the exam this month, 25? No one. Oh. Dr. Omar, you need to take it or we'll leave it to Osama or what? Okay. Osama again. All right, Dr. Osama.
Okay.
Doctor, so again, of course, you are Dr. Richard, SHO to Mr. Wilson. So you will call Mr. Browse, the consultant, short today to tell him about. I just to confirm, I share the screen or not.
Okay. Can you share?
Okay, I share it. Okay. So the consultant in charge today to tell him about a case. This is not under his supervision. It is important in exam to know usually what you call him is not necessarily this case done by him. But they have a habit in UK, we don't call anyone if not in duty. Miss Anne Mary is the name of patient who is operated yesterday for laparoscopic cholecystectomy and have bile coming from the drain. So again, a 45 years old woman complaining of abdominal pain, mainly in her right upper abdomen after fatty meal, pain radiated to right shoulder, pain score 7/10, nausea, no vomiting, no change in urine or stool color, no itching. She is overweight, BMI 33, and non-smoker, not drink alcohol. Uh, she is housewife, married with 3 children, abdominal ultrasound, multiple small gallbladder stone, and chest X-ray is normal. Of course, all this is the past history now, because this patient already operated by Mr. Wolfson. Ruben is a anesthesia, and she did for her laparoscopic cholecystectomy. There is a lot of adhesion till reach the calloid triangle. We use a harmonic scalpel. Harmonic scalpel is ultrasound way for hemostasis, not a diathermy for dissection of adhesion. Tube drain is inserted in the right hepatorenal pouch. Post-operative day 1, vital sign blood pressure 130/80, pulse 110, temperature 38 degrees centigrade. On examination, tinge of jaundice, abdomen slats, bile come from the drain with no change in urine color. Urgent abdominal ultrasound show minimal intra-abdominal collection, but no intrahepatic biliary dilatation. Full blood count, we can found leukocytes 11, hemoglobin 13. Other, I think, is normal. Liver function, apart bilirubin is normal. Urea is normal. Creatinine is normal. Arterial blood gases, I think, also is normal. Medication is okay, no mention. Flow chart is okay. Chest X-ray is okay. All right, Dr. Osama. So you need to show anything or we can start?
Yes, I need to show the name of the consultant patient to call and some data in the first.
Okay, good. So the consultant you call is, just a minute, is Mr. Browse. And the consultant who makes the operation is Wolfson. And the patient name is Anne Mary. Okay, and you supposed to be Richard. If you forget your name, just tell Osama, no problem.
Yeah.
Okay, I just go to the educations. All right, well sold. Okay, if you're ready, you can start.
Okay, I'm ready. Hello,
Okay, hello, yes.
my name is Dr. Osama. I'm SHO doctor working to the Mr. Workman. Please, can I
Yeah.
check to the take to the Mr. browser about
Yes,
the
I'm
patient?
Mr. Browse. Yes.
Hello, my nice to meet you, doctor. Doctor, I'm Doctor Osama SHO. I'm working to the
Okay.
Mr. Man. I need to call you to inform you about the patient second day post lab cholecystectomy. Patient have bile in the drain. Please,
Okay,
can I?
so if the patient have bile in the drain, what is the possibility for that?
Yes, the possibility maybe four things. First of all, maybe patient have a bile leakage from the bed of the gallbladder, maybe slippage of the clips, and maybe due to injury of the common bile duct or any accessory hepatic duct.
All right, okay. All right. Okay, is this patient in obstructive jaundice?
No, is the patient is not obstructive jaundice, is the normal total bilirubin and the direct. and indirect.
Okay, so what else you are sure that she's not in obstructive jaundice?
Yes, obstructive jaundice and the clear of the urine. Maybe the kind of patient is the obstructive
Okay,
jaundice. Mhm.
because the urine is
Is the
not tea
clear
color, not dark color, and the bilirubin is
is the
normal.
normal.
Of course, if the bilirubin is high, you're looking for direct bilirubin.
Yeah.
Okay,
Uh-huh.
so suppose this patient have jaundice now. What is the possible cause? This patient, second day, third day, within 1 week, have jaundice. What's the possible cause?
Yes, the possible cause could be the patient have slipped stone to the common bile duct, and could be the clevis in the common bile duct, or any collection inside that lead to the compression in the common bile duct.
Okay, so usually either slipped stone or iatrogenic or wrong clips
Slipped
or
stone.
lecture put in common bile duct. So if this patient have jaundice after 1 month from surgery, what it could be?
What's the question,
1 month.
please?
If this patient have jaundice 1 month after surgery,
Yes, one
one
month after
month.
surgery, maybe. Yes, maybe the slipped stone, one of the causes.
No, no, a slipped stone can cause jaundice in the same day, not after 1 month. If the slipped
Mm-hmm.
stone during surgery, so the patient become obstructive jaundice in the
Oh
same
yes,
time.
maybe strictures, maybe some strictures in the common bile duct or
Due to
any
what?
uh, stricture due to any inflammation or any infection or any
No, no,
uh,
inflammation in common bile duct is very rare. It can due to stricture due to injury. If they have
uh
iatrogenic injury, either by cautery or diathermy or by
yeah, yeah,
manipulation in the common bile duct, so or partial injury, they can cause stricture. This stricture
stricture
to be
after 1 month.
presented take 1 month. So we have
Yeah,
two possibility. If the patient post-operative after laparoscopic cholecystectomy came to you with obstructive jaundice, so the first possibility is slipped stone in the common bile duct. The second is iatrogenic lecture or clips put in the common bile duct. If it is
yeah,
after 1 month, so sure it is injury. This is injury occur at time of operation and healed by stricture. So the patient presented by obstructive jaundice late. Okay.
yeah. Okay.
All right. So is Mr. Wolfson used to put a drain in laparoscopic cholecystectomy? Why he put a drain in this case?
Yes, because the patient mentioned in the note of the operation, patient have some adhesion and some resection, and that's why the doctor put the drain maybe to look and show if have any bile leakage after operation.
Okay. Is this patient now have biliary peritonitis?
Uh, yes, yes, the patient has have biliary peritonitis. Yes,
No, no, no. Relax, relax. Biliary
no trigger.
peritonitis mean accumulation of bile in the
Oh
abdomen.
yes, I'm sorry, sorry. Patient have a drain and no accumulation, no
Okay.
peritonitis.
So
Yes,
it is
yes,
important if the patient have a drain. So this is drain, and some doctors say it is the eye of surgeon inside the abdomen. So
yeah,
suppose the patient have an anastomotic leak in hemicolectomy, so the drain show the intestinal content. If the doctor have injury of common bile duct and have bile inside the abdomen, the bile come from the drain. So
yeah.
in this patient, if you have a drain, so it is impossible to have biliary
Biliary
peritonitis
peritonitis.
simply
Yes,
because the patient is already have a drain.
yes. It's get
Suppose
out.
this patient don't have a drain and the collection of the bile inside the abdomen. What you will do
Yes,
for this bile?
yes. I can do to the aspiration and ultrasound guide
Okay, so it's called percutaneous drainage because you put a tube guided by ultrasound.
by
It is
ultrasound.
not
Yeah,
drainage. We do drainage for ascites, but this is not ascites. Bile is very irritant to the intestine. So we put a drain guided by ultrasound and leave it. So it's called percutaneous drain guided by ultrasound. All right. So this patient now have bile leakage. How to manage this patient?
yes. I need to manage the patient. I need to do MRCP to show the
No,
site of
no,
the
just
leakage.
doctor, relax, relax. Doctor Osama, relax. This is patient come to you. So you see this patient now. So you put a cannula, intravenous fluid, antibiotic to avoid ascending cholangitis, so give here cephalosporin and metronidazole, and can do
It's not disease
ultrasound and
management, you mean?
prepare for.
Yeah.
Okay, so you can start how to manage this patient.
Yes, I will start manage the patient to start to give IV fluid and give antibiotic to the patient and good hydration of the patient and give analgesia. And after that, I need to take another investigation from to the patient to the check to the liver function again. And I need to and hello, you are
Yes,
listening
yes,
me?
I hear you.
Yes, and I need to take another investigation to show to the
What is
hemoglobin.
this you mentioned? It is ERCB. What is ERCB?
ARCB is endoscopic retrograde cholangiopancreatograph.
Or what is the value of it now?
What?
What is the value? Will you do by ERCB?
Yes, ARCB is diagnostic and therapeutic, and is we go to the endoscope from to the mouth and pass the ampulla of
No,
water.
we don't ask you about detail in this patient, what you will do by ERCB, not how to do ERCB.
Yes, it's doing as diagnostic and therapeutic. Diagnostic show
Yeah, I
leakage
know,
and
but
let
in
me
this
put the
patient,
stent.
what you will do?
Yes, you put the stent inside the
You
site of the
remove,
injury.
you have a stone, most probably, so you remove the stone,
Yes,
and if it is have injury or something, you can put a stent. So you remove the stone first and
put the
put a
stent.
stent,
Yes,
or if difficult to remove the stone, you put a stent. Okay?
you put a big
All
large
right.
stent.
So
Yes,
before that or at the end, what you need to tell me?
I need to summarize the case of the patient.
Okay, go on.
I have the patient 35 years old. His operation done today back by the Mr. Man, and the patient now he has a drain and have a bile in the drain, and the patient could be suspected to have the injury of the common bile duct, and the liver function is normal and need to send to the hepatobiliary to do a definitive management for this patient.
Okay. All right. Thank you,
Thank you,
Dr.
doctor.
Usam. All right. So again, as you see, the condition is easy. Everything is written in the file. I have one scenario left. It is about trauma. So I just read the scenario, and after that, we can show. Okay. So you are Dr. Richard. Of course, in the exam, it is important to have a paper. You have already paper, and depends you write. Are you supposed to be Dr. Richard? Emergency department usually will tell you what is your rank, like you are SHO. Sometimes you have CT. CT means that core training. It is like houseman, like internship in Egypt, or you are specialist. SR means specialist registrar. So of course, if you are SHO or core training, so you need to consult more senior. You are SHO in emergency, you will call Mr. Brown, the consultant in charge today, to tell him about trauma case. So what we have here is a 35 years old man come to emergency after RTA 30 minutes ago. Airway is patent, patient can speak, breathing is normal, no tracheal deviation, no percussion and auscultation, Glasgow scale 13, right eye slight dilated, vital sign blood pressure, pulse. He has left open fracture tibia and no pulse in his left dorsalis pedis artery. Send a sample for group and safe. Send sample for food blood count, blood sugar, arterial blood gases. Hemoglobin 7, I give him 1 unit of blood. X-ray show left fracture shaft femur. I inform orthopedic team and the vascular consultant. The abdomen is normal, confirmed by fast scan. On the skull X-rays, they have battles. On the skull examination, they have battle sign, right side hematoma. Fast scan is normal, chest X-ray normal, cervical lateral view normal, abdominal pelvic X-ray normal, CT brain waiting for the report. If the right waiting for the report, so most probably the examiner show you the CT. And secondary survey, EMBL, ample no allergy, no history of diabetes, hypertension, last meal 4 hours. Event is a patient driving a car wearing a seat belt and hit a tree. Orthopedic report, fracture shaft femur, Type 1, a clean wound that is less than 1 centimeter long wound, something called the Gastello-Anderson classification. Distal pulsation not felt. This is important. The urgent surgical interference with the vascular consultant. Vascular opinion, dorsalis pedis not palpable by handhold Doppler. Full blood count is here, hemoglobin 13. Liver function test till now normal. Arterial blood gases within normal. Medication is okay. Fluid chart, chest X-ray. This is what we called it battle sign, and this is the CT. Okay. So anyone volunteer?
Okay, doctor.
Okay, so we can start. I just share what I have. Okay, you can start.
I'm Dr. Richard, working
Okay.
for Mr. Mann. Can I check that I am calling to Mr. Browse?
Yes,
That
I
work.
am Mr. Browse, the vascular consultant today.
Okay, I have patient Mr. John, 30 years old. He present with a road traffic accident, showing for now absent peripheral pulsations of his left limb and showing open tibia fracture, and also had trauma to the head, which showing hemorrhage.
So why you
signs.
call me doctor?
I call him because refer for to saving the limb of the patient.
Okay, so you need me now or can be waiting till tomorrow?
I need to do urgent transfer now to saving the limb
I do
of
the
the patient.
transfer, but you need me to go to the hospital now or tomorrow. I can operate it to him tomorrow.
No, it's urgent. It's need urgent intervention to save his limb, as the pulse is absent.
No pulse. Okay, all right. So in the notes, you mentioned this patient have battle sign. What is this battle sign indicate? Or
Battle
roughened
signs
eye,
indicated basic skull fracture.
basal skull fracture. Okay, all right. So in the pupil, you can comment in the pupil.
The pupil, the patient showing dilated pupil,
Okay, if it
which
is dilated right side, it means that the hemorrhage is right side or left side?
left side.
No, it is the dilated pupil in the same site of lesion.
Okay,
Dilated pupil is if the patient have right extradural, so dilated right, not the other side. Other side can be paralyzed. Okay, it's very
okay.
important. Glasgow scale is okay. All right. Uh, I
Glaucoma
just
scale,
ask you,
not
what is
okay. Glaucoma scale is
Glasgow scale? What is in Glasgow scale? Like what you test in Glasgow scale?
Glasgow scale is 13 over 15. I will assess Glasgow scale according to eye signs. If response spontaneous, I give 4, and also response to
Verbal.
verbal 3, and also to the pain 2,
No, we
and
don't tell
also
details. We don't tell details. Just it is response. I
okay.
have
I
a
will
score
assess
of eye out of 4, verbal out of 5, and the motor out of 6. Okay.
okay.
So if this is what is the value to know it? It is the Glasgow scale is less than 8. What you will do?
8, I will do urgent CT.
No.
Which
Just my question. If you are in emergency and the Glasgow coma scale is less than 8, what you will do?
firstly, I will consult the neurosurgeon, and
No, we don't consult. You are emergency doctor or in emergency room, and the patient have Glasgow scale less than 8. Anyone knows the answer? It is like, what is the indication? Yes? Mustafa,
Below 8 intubate.
intubate. So this is patient must, if
Okay.
it is below 8, you must put intubation. Don't call the consultant, don't send it for CT. You will kill the patient. You need to put endotracheal tube. After that, you can consult anything. All right.
Okay.
Okay. So glaucoma scale is important for that. You mentioned in the report something called ample history. What is this? AMBLE.
Ambil history.
What is this?
That's include no allergy or
So A for allergy, M for medication, B
medication.
for the past history, L for last meal. So what is important to know the last meal? If this patient come from restaurant and have an accident, what you will do for him to avoid what?
Aspiration.
You avoid aspirated pneumonia by put what?
Chest tube or
No, doctor, relax. Not chest tube, nasogastric tube.
nasogastric tube.
Not chest tube or potential pneumothorax. So we put nasogastric tube. Okay, we mentioned in the report also fast scan. What does fast scan mean?
Fast scan is focused focus sonography for
Assessment
the abdomen.
sonography for trauma.
Assess
Focal
fluid in
assessment.
four areas.
Doctor, we don't, in exam, we ask you about 20 questions in 10 minutes. So he ask you, what is fast scan? Is focal assessment sonography for trauma. I don't ask you about detail. Can be the next question or can be in other station. So if you are in each question, speak a lot, you lost your time, and management of time is very important in this exam. Okay, so fast abdominal scan or focal abdominal sonography for trauma is just this word. Of course, it is right side for liver, for spleen, for cardiac tamponade, and the lower for free fluid. Okay, we show you the picture. I think this picture. What is your diagnosis?
By this showing by convex hyperdense mass on the right side, shifting midline, and also compression on the ventricles, which may be extra.
No, it is maybe or it is
extra. My provisional extra dural hematoma.
What is usually the cause of that? Which
Trauma
artery?
to middle meningeal artery.
Is middle meningeal artery is branch from which artery?
Maxillary.
And the maxillary is branch from?
Internal carotid.
External carotid.
External, sorry.
External carotid. Okay, and go through the skull through foramen?
Maxillary?
No. Middle meningeal.
Middle meningeal spinous.
Foramen spinosum. Okay. So usually it is arterial. What about subdural hematoma? What is look like subdural hematoma?
It's like lens shaped.
Lens or crescent shape or something like that, and it is venous or arterial?
Bridging veins or cerebral
so
veins.
it is venous. Okay. All right. So you mentioned that this patient have ischemia and you need to transfer to me. So how to confirm that this patient have ischemia or how the dorsal species is not felt? How to confirm that?
Firstly, doing arterial duplex and also
no, doctor, duplex is in the radiology department. What in the emergency department? What we call it?
CT pulmonary angio.
No, doctor, relax. You see the picture or not?
I see.
What is this machine called?
Ankle brachial.
No, doctor, just to make it easy, it is handheld Doppler.
Okay.
So you can confirm the dorsal species is not felt by handheld Doppler. Duplex is other machine. It's like ultrasound and shows the intima and all this. We don't need it. Okay. So in this patient, you mentioned it is open
Okay.
fracture. What you mean by open fracture?
Open fracture is exposed of soft tissue, which
So you have a wound.
may okay. Yeah.
Okay. So if you have a
Fracture
wound,
that
how to fix the bone now? What is the ideal process to fix the bone in this open wound?
firstly clear the wound and the debridement of necrotic tissue, and also fix the fracture by external fixation.
Okay, so correct external fixator. Doctor, what's your name? Not Hamza. What's your name? Hamza.
Hamza.
Dr. Hamza, this is attitude in exam is very fatal. You don't enter the exam before, I think.
Yes.
Okay. Okay. In exam, we have about from 15 to 20 questions in 9 minutes. Okay. So what is the way of answer? For example, if they have open fracture, mean wound, how to fix it by external fixator. That's it. Okay. Because if you speak much, you lose the time. So you need to be in the point. Okay. So mention open fracture, have a wound. What is mean by communicated fracture or comminuted fracture?
Comminuted fracture may be the disruption of the wound and the extravasations of
No. It's not related to the wound. No, doctor, open fracture or compound fracture is other topic, but comminuted means the bone itself is more than one piece, like 2, 3, 4 pieces.
Yes.
Okay. Of course, the fixation can be internal, external. Usually, if you have bleeding, if you have wound, we do this is external fixator. Okay. We don't do internal fixator. In some centers, if you have many, you can do something called the Lazaroff, but it is the same external fixator. All right. So what you expected as a vascular surgeon to this patient?
As a vascular surgeon,
Yes.
bypass and also
So bypass or repair the injured area. Okay. All right. So at the end, what you need to tell me?
I will to accept my referral for this vascular injury to save the limb of the patient, which is need urgent intervention to save his limb as the pulse is absent, and also we can manage the open fracture of left tibia.
Okay, it is managed by orthopedic team, is not my job. But you know that we are in the same hospital. You refer to me, but I am in the same hospital. So what else you need to do for me?
As a vascular?
Okay, you call me. Okay, doctor, you agree? You call me. And you are working in the same hospital. And you ask me to come today. So I will come soon. So what else you supposed to tell me?
I would like to save the limb of the
No.
patient.
Doctor, can you look into the screen? You see the screen now.
Okay.
Okay, so Mr. Browse, I will be ready in the theater waiting you. I will inform orthopedic and vascular team and of course anesthesia. Okay? I just write anesthesia and the vascular team. Okay, you understand the idea. If you work in hospital, you are working in surgery or you still in, you work in hospital or not?
Taklif.
Taklif, okay, all right. All right, so if you are working in hospital, suppose you are working hospital, inshallah, so you call the consultant, so at the end you tell him, okay, the theater is ready, I call the anesthesia, I call your houseman or the vascular team or whatever, and the nurse of all these are ready, waiting you in the theater, or waiting you, and we can start the operation. So this is
also
what
neurosurgeon?
run an exam. Yes?
Also may consult a neurosurgeon or not?
No, of course not. Yeah, we don't need. And neurosurgery is not urgent in this situation. Okay.
Okay. Okay.
Thank you. I just summarize everything. So as you see, all is first thing in